Good morning. Welcome to the 5th Sickle Cell Data Collection for California webinar series. I'm Faith Rader from the California Rare Disease Surveillance Program, and I will be today's moderator. We're going to get started. We've got a lot to cover.
Wonderful. So thank you for having me. So what I wanted to talk to you about today is translating health services research into in sickle cell disease to health policy. And so I have several objectives for today. So the first one is just to give a brief definition of health services research. A lot of you know what that is already, but I just want to give a brief definition. And then demonstrate the relevance of HSR to sickle cell disease. And then really transition into talking about something that I think as researchers we often think about with respect to the sickle cell disease population, but often feel frustrated in terms of what to do about it, is the social determinants of health. And then lastly, what I want to do is highlight priorities for incorporating the social determinants of health into sickle cell disease research. So first of all, the definition of health services research. And so the Agency for Healthcare Research and Quality defines it as something that examines how people get access to health care, how much care costs, and what happens to patients as a result of this care. The main goals being to identify the most effective ways to organize, manage, finance, and deliver high-quality care, reduce medical errors, and improve patient safety. So here's another definition from the Institute of Medicine. So a multidisciplinary field of inquiry, both basic and applied, that examines the use, cost, quality, accessibility, delivery, organization, financing, and outcomes of healthcare services to increase knowledge and understanding of the structure, processes, and effects of health services for individuals and populations. And so there you have the basic definitions of what health services research is, and then what we have to think about next is what is the end goal? And what we talked about a couple weeks ago at the Public Health Grand Rounds, and what I'm talking about today, is achieving this triple aim of healthcare for population health. And this involves three goals or aspects. So one is to reduce costs, and that may be reducing redundancies in care that'll reduce cost, or making sure that we don't misuse care in certain ways that increase cost. The second one is to improve population health, so looking at different inconsistencies or variability in care across a population, taking that information and then using it back to actually improve care processes. The last one is enhancing patient experience, so really being able to incorporate what a patient's experience in healthcare is, taking that information, incorporating the family or patient into making healthcare improvements within the system. So again, this triple aim of healthcare really involves reducing costs, improving population health, and enhancing patient experience. And so that, if that's the goal of getting to this triple aim of healthcare, then how do you get it? And so one model that was outlined years ago by Doherty et al. Is this roadmap of high quality care. So it starts off with the basic sciences and clinical efficacy research, then moving on towards outcomes research, comparative effectiveness research, and then, as we've been talking about, health services research, where you're trying to figure out what works best in what settings. And then from that standpoint, then you take it to the next level of really trying to see how things work in the real world. And once you get there, then you can have some more discussion on what the policy implications are and how to actually make change across the board. So then talking about the relevance of health services research for sickle cell disease, there are a number of opportunities and challenges in sickle cell disease, as we've discussed it many times. So one is, in terms of opportunities, you've had the advent of all these diagnostics tools and treatments. So we have hydroxyurea as a disease-modifying medication. We have TCD screening to assess for stroke risk. We have chronic transfusions to reduce stroke risk. And all of that has really helped to lead to an extended life expectancy for individuals with sickle cell disease. But we also have a number of challenges. And so what we've seen from the research that all of you've done is that there is persistently high resource utilization among this population, both with children as well as adults. And then you have this high risk of mortality at early adulthood. So when young adults are transitioning from pediatric to adult care, you see that there is this great risk of mortality as well as morbidity. So something in the transition process really goes awry. And then, as we understand, this is a largely underserved population, mostly minority. A lot of patients, when we do our studies, most to 2/3 to 75% of the population will be publicly insured, which is an indicator of just socioeconomic stress. And then lastly, when you look at sickle cell disease, there's poor funding and organizing relative to other conditions. So whether you look at funding at the federal level or the foundation level, or just organizing overall, you just don't see the type of resources investment in sickle cell disease that you see with other conditions such as cystic fibrosis. So now that creates a number of challenges when you talk about conducting health services research for sickle cell disease. So it means you have inadequate funding due to overall low prioritization of sickle cell disease. It means you have few dedicated researchers. So if there's not a lot of money in sickle cell disease or ways to really kind of move your career forward, you're going to have few researchers. And as we've talked about a number of times, just a lack of data sources with adequate numbers of children with sickle cell disease or sufficient clinical data. So this is where it gets back to the work that Mary is doing and the importance of that in terms of really trying to get adequate numbers. And then controlling for disease severity is always a challenging thing in terms of trying to figure out what defines the disease severity. And another thing is just what are the quality indicators that we have out there to be able to say these are the benchmarks that both adults and children should be achieving, so we know what is good care and how do we assess it over time. So there are a number of data sources that we use for health services research in sickle cell disease, and they all have their benefits and disadvantages. So let's just go through those. So one, in clinical settings, you can start off with chart review. The advantages are you can have large numbers of patients. You have a great amount of clinical data. You can get genotype, which is helpful. You have charge data. You have provider type in terms of whether being seen by primary care, specialists, hospitals, et cetera. But it has a number of disadvantages. So it's very time-consuming. It's not generalizable. You don't get a lot of demographic information. So you'll have their insurance type. You may have race and ethnicity, gender, but not a lot of other information. You won't obviously get information outside of that particular institution, so that limits what you're able to say about what you're finding. And then what I found in my research in the past is you have this big question of will the institution actually let you publish your work? So for example, I think one of my first papers was on looking at the extent to which children with sickle cell disease underwent TCD screening for stroke risk. It was one of those things where I did the chart review, and then we found that less than 50% of our patients who should be getting TCD screening were actually receiving it. And it was one of those things where it's like, oh, this is a great result, and you show it to everybody. Then there was this concern by leadership of, well, that's great, we'll use it to make some internal changes, but we can't really let you publish that. And so what happened over time is we were able to find at least some data out there that showed that other institutions nationally had similar rates, and then that increased the institution's enthusiasm for me submitting that paper for publication. So I think it's always a question when you're working at a single organization, an institution, or a hospital as to how that institution will feel about the release of that work. So I think, to me, sometimes that could be one of the big poison pills in trying to do chart review. Insurance claims data, we've seen a lot of papers with insurance claims. So again, you can have large numbers. For the most part, low cost to really get these data sources. You get all different types of services from primary care to specialty care. You get prescription data as well, and you'll also get expenditures. So all those things are wonderful. But then in terms of some of the disadvantages, you have high turnover, particularly if you're looking at public insurance databases. And then there just aren't a lot of private insurance databases out there to supplement. Sometimes there are issues with availability of current records. Again, there's this issue of lack of socio-demographic variables. And sometimes it's hard to generalize, even if you have a large insurance plan that you're working with. And so what people may use is they may use individual managed care organizations to do their studies for sickle cell disease. They may use an individual private payer plan, a state Medicaid. I think there have been tons of state Medicaid studies out there on sickle cell, both from, I believe, North Carolina. There have been several from Maryland as well. And then there's also the Market Scan Research Database, which compiles claims data from a number of states, but again, it's limited because you have a number of states available. And so now another option is administrative databases. So the advantage of these databases is that you'll have ICD-9 codes, procedure codes as well, large numbers, low cost, you have the charges available. But some of the disadvantages, you can't really integrate the clinical data really well into there, so there's some limitation there. You don't have outpatient medications. You don't have any sense of what type of outpatient care is occurring, so you can't really connect the inpatient with the outpatient. And then at times, the discharge may be the unit of analysis rather than the patient, so you may not have individual identifiers for patients, so you can only talk at the level of the hospitalization if it's inpatient. And then sometimes there may not be cost data. And so examples of what people have used for sickle cell disease, I think a lot of people now are really getting into the FIS database, which is the Pediatric Health Information System. And what that offers is a lot of administrative database, some clinical information as well. So I think that is one that is really well utilized now. The limitation to it is that it's just children's hospitals, so you won't get information about community hospitals or general hospitals, so it would only be about the experiences of individual or children with sickle cell disease in large children's hospitals. And then other sources we've seen used have been the Healthcare Utilization Project, so HCUP, and people have used the Kids Inpatient Database as part of that, or the State Inpatient Database as part of that. And David Brousseau had a large paper on rehospitalization in 2010 that came out of the HCUP database. So there is a potential to really look at sickle cell disease within these large databases. So now talking about a last option is national survey data. So the advantages are, oftentimes these databases are free, so there's no cost. You have some information on sociodemographic variables because it's more survey-based. You have a wide array of questions and outcomes, and it is potentially generalizable. The disadvantages here in terms of sickle cell disease, a lot of times the numbers for sickle cell disease are going to be extremely low, and oftentimes they may not even ask about sickle cell disease. You obviously won't get information on genotype, and a lot of what you're relying on is self-report. And some of the questions that you'd want to know about sickle cell disease aren't necessarily there, and you will not have any financial data. So some examples of databases people have used for sickle cell disease. So there's the National Survey of Children's Health. It does not specifically ask about sickle cell disease. It may ask for, does your child have a blood disorder such as sickle cell disease, but that's the furthest it goes. The same with the National Survey of Children with Special Health Care Needs. There is the Medical Expenditure Panel Survey, which is called MEPS, and that does allow a patient or individual to identify themselves as having sickle cell disease, but the numbers are so low that you essentially have to collapse 10 years worth of data just to get about 100 person sample. And it's the same thing with the National Health Interview Survey. So those are some significant limitations in trying to sort of take what's out there on sickle cell disease on a large scale level and really produce some high level research that can influence policy. So now what I want to do is transition a little bit. So there has been all this great work on sickle cell disease with respect to health services research. And I think what usually sort of is a frustrating point for a lot of us as researchers is that there are all these social determinants of health in the background. So what's the influence of income? What's the influence of poverty, race, ethnicity, stigma around disease? And it's hard to really kind of get at those factors using the current data sources that we have. So I think it's useful to really talk about how do you actually incorporate social determinants of health into the research that we do, because I think it could be so much more meaningful if we had more access to data about social determinants of health. So let's first talk about how it is defined. So Healthy People 2020 defines it as the conditions in the environment which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risk. And if you look at the World Health Organization, it's also very similar, and it really focuses as well on economic policies and systems, developmental agendas, social norms, social policies, and political systems. So those are your high-level definitions of what social determinants of health are. And related to that, what people are also increasingly talking about is something called the adverse childhood experiences. The ACEs is the short term of what a lot of people are using. And the reason that people have gotten so focused on this is these ACEs really influence what happens with outcomes for individuals long term. And the understanding is that you have all these childhood experiences. They could be positive or negative, and they're going to have impact on your long-term outcomes. So ACEs have been linked to risky health behaviors, chronic health conditions, low life potential, as well as early death. And what researchers have found is as you increase the number of ACEs children experience, so does the risk of these poor outcomes for individuals. So oftentimes what people will be doing is they'll be interviewing adults about these ACEs they may experience as children, and then what they do is they study their relationship with specific chronic condition outcomes that those adults are experiencing. So ACEs is something that has also really put to the forefront the whole importance of social determinants of health. So now let's take a look at social determinants of health and what's going on in the current health policy landscape. So one aspect is the Centers for Medicare and Medicaid have come up with this accountable health communities model. And the idea is that there's a focus on the health-related social needs of Medicare and Medicaid beneficiaries. So, and what these accountable health communities model involves is really building an alignment between clinical and community-based services at the local level. So what does that mean practically? So that means really creating a system where patients can come into their local service providers and get access to patient navigation services, community health services, really be connected with community agencies that really can help them get the types of services they need. So you can come into a clinical setting and really be well connected to what you need once you leave that clinical setting. So what CMS has done is it's funding a number of organizations to really try to do this work in a fundamentally different way than we've done previously. So really putting the social determinants of health at the center of what a clinical operation can do. And so here's another example, is CMS has also started the State Innovation Models Initiative, so SIM. And where we were talking before about the accountable health community model, which was really focused on funding towards individual organizations, hospitals, practices, et cetera, SIM really is more oriented towards the state level. So states are being engaged in these multi-payer delivery and payment reforms that focus on population and social determinants of health, such that states may be incentivized to focus more on social determinants of health. So all of that really has some great implications for sickle cell disease. And then another sort of focus in the policy arena is this health in all policies approach that some of you may have heard of. And it's this idea that with any decision is made in various sectors, whether they be busing, crime, built environment, education, that whatever decisions are made in that sector also take into account how those decisions will impact health or promote the aims of health. And so some examples are the National Prevention Council, which was created by the Affordable Care Act, where you have a convening of, I believe it's approximately 20 federal agencies that really work in that cross-sector fashion to look at how policies really impact health. And an example that you folks in California may know of is the California Health in All Policies Task Force, which essentially does similar work where it's looking at the effect of policies across the board to really impact health. So that's another way of showing that there is momentum towards really incorporating social determinants of health into what we do, into providing clinical care and research. So for sickle cell disease, I think it's pretty obvious why social determinants are so important in terms of now starting to bring them more into how we do health services research. So again, as I said before, we have a largely racial ethnic minority population. We have a high percentage of individuals who are publicly insured. And then there's also this issue of disease-related stigma. So, and there are a host of other things that we could talk about at the same time. I think these three factors alone really state conclusively that there is a great need to really incorporate social determinants of health into the health services research that we do for sickle cell disease, because that can have implications on policy. So what's the potential value of really incorporating social determinants of health? And this is a great paper by Laura Gottlieb, who is out in California, so some of you may know her. She was my medical school classmate. And this is an article that just came out in Health Affairs this month on assessing social determinants of health. And what she outlines is a number of benefits. So from a clinical perspective, it can help providers understand how to improve their panel management. So if you see what kind of social determinants of health risk factors are occurring in your population, you can figure out what you need to do in terms of support services, social work, patient navigators, care coordinators, et cetera. You can also use it for quality improvement projects. So you can see what types of social determinants your population is experiencing and then be able to gear your quality improvement projects towards some of those social determinants of health, or just kind of account for them. So if you understand that you have a population that doesn't have access to cell phones and mobile devices, then maybe you don't do a quality improvement project that focuses on having technology. It can also help with staffing for team-based care, again, in terms of care coordinators, navigators, et cetera. And then it could also be incorporated into performance-based incentive payments, as we discussed before with some of the initiatives CMS has taken on. For researchers, I think it also has great value in a number of ways, and I've just listed two down here. One, just better accounting for influencing factors. So I think in a lot of the research that we do on sickle cell disease, what we come down to is, oh, there's this factor of socioeconomic status. All we really have in this database is really insurance type, and that's our proxy. That's our best proxy that we have. But I think if we were able to more comprehensively get in all these other social determinants, we could better say what is actually having the true influence. And I think also having that information, secondly, would really help us with intervention design. So you can say, we're going to either target our intervention towards these social determinants of health, or we'll be able to account for these social determinants of health in our intervention design, or incorporate the community in this intervention in a way that actually makes sense for the research. So this is some of the potential value of really looking at social determinants of health in our health services research. And so then the question becomes, what is the feasibility of measuring social determinants of health? Is it in electronic medical records? Is it in administrative data? If it's in surveys, how do we do all that? And so there is a little bit of guidance out there on how to do it. And so the Institute of Medicine released a report called Capturing Social and Behavioral Domains in Measures in Electronic Health Records. And this report recommends variables measuring social and behavioral factors that should be incorporated into electronic medical records. It doesn't exactly say how, it just says should, which is a funny thing. And so here are the recommended domains. And the first four are ones that are routinely or typically captured already in electronic medical records. So alcohol use, race, ethnicity, residential address, tobacco use, and exposure. But then there are all these others that they outline that would also be helpful to know. So knowing what the census tract median income would be, symptoms of depression, education level, financial resource strain beyond insurance type, intimate partner violence, physical activity, social connections, and social isolation, as well as stress. So all of this gets back into the social determinants of health, the adverse childhood experiences. So it's sort of a theme that kind of comes together. And the IOM is saying these are the domains we should be capturing. And if we can capture these domains, then we have a very good sense of the social determinants of health that this individual is experiencing. And if we look at a population health level, we can put all this information together and get a sense of what are the social determinants of health across a population. So the place I want to end is not necessarily with a summary, but a number of questions that we really need to think about. So the first one is, as we look at these domains, and I'll just go back here, are these domains the most relevant to sickle cell disease? So if you all had the opportunity to design some type of survey instrument, would these be the ones that you would have for sickle cell disease? Would there be other ones that you would include there in order to get a true sense of social determinants for sickle cell disease? So that's the first question. The second question is, what survey instruments actually should be used? So I think in Laura Gottlieb's paper in Health Affairs, what she talks about is, we've had this great proliferation of all these survey instruments that really assess social determinants of health, but it's unclear which one we use because they're all very similar. So there is the Adverse Childhood Experiences Survey, which is typically given to adults. So that's one that we could potentially use. There's the Seek model, which a lot of primary care clinics, at least in pediatrics, have used at well child visits to really get a sense of intimate partner violence, food insecurity, et cetera. There is another one called the WeCare tool that I think was really tested and trialed by investigator in Boston, Arvind Garg. So that's another one. And there are several others out there that are either percolating or sort of coming to the surface as other potential instruments to use. So the question becomes, which one is the best one to use, especially if they're all sort of the same. And then the next thing, is it possible to standardize these instruments across systems? So if everyone is really invested into assessing social determinants of health, is there a way that we can standardize it so that we're not working off of different surveys, so everyone has the same information? And then the next question I put out there is, when should these surveys be conducted? Should they be conducted one time? Should they be conducted at a routine visit? Should they be conducted in an emergency care setting? And how often should they be conducted? Just once? If you follow up, how many times should you follow up? And when should you follow up? So trying to figure out what's the right dosage of getting that information and then incorporating it into our either quality improvement interventions, research interventions, or just understanding sort of the epidemiology of what's going on with sickle cell disease. The next question is, what resources are available to incorporate these measures into electronic databases? So, to put this into an electronic medical record like an EPIC or a Cerna, are there resources available to actually do that effectively? And can we do that across a number of large electronic record sort of data storage houses? And then the last question I bring up, which I think a lot of people neglect to think about because there's so much enthusiasm about really incorporating social determinants of health into health services research as well as sort of policy. Is it ethical to screen for social determinants of health without the resources in place to address them? So for example, if we say we want to get a greater sense of the social determinants of health around our sickle cell disease population, so now as we conduct this work in California or Atlanta, we're going to routinely ask about food insecurity. So we have all this great information at a population health level, but in that individual context of a patient interaction, if the provider doesn't have access to resources for food insecurity, is it really ethical to ask those questions? Same thing with intimate partner violence. As you think about all these questions that are geared around the social determinants of health, are we really equipped to do that if we don't have the resources in place? And also, I think once we start measuring these things, we also have to think of the more multidisciplinary team that involves social work, care coordinators, et cetera, that could really take some of the accountability or share some of the responsibility about providing patients with access to these resources. So I think the goal of my talk today was, goals were really twofold. One was to talk about, where are we now with health services research for sickle cell disease? We have all these data sources. We know their benefits, we know their advantages, and we know their limitations all too well. And I think the thing that's, for me as a researcher who's been doing this work for a while now, is what comes out to me is that we still haven't addressed these social determinants of health in our patient population. And we know they're there. We know they're strong. Whether we're clinical providers, epidemiologists, or people who work in state and local agencies, we know they're there. So then the question is, how do we actually study them? How do we address them? And how do we pick out the right ones that are actually meaningful for sickle cell disease? So I think that's why I leave you with these questions here. So I'll stop there, and I'm happy to take questions.
So again, please submit your question by writing it in the question box on your screen. We have this line for another 20 minutes until 11, and we'll end the question and answer by 11. So Dr. Raphael, I don't know if you can see the questions, but one has come in from Nancy Renee saying the social determinants of health seems to blame the patient. What do we do about lack of sickle cell specialists and implicit bias of the medical professional?
That's great. I mean, I think, I don't know that I would say it tends to blame the patient. I think the ideal scenario is that social determinants really incorporates the patient's experiences in environment before they even enter into the healthcare sector. I think that's really the function of really focusing on the social determinants of health, is really saying if you're truly just focusing on the healthcare sector, you're really limiting yourself in understanding who that patient is. I think when we talk about implicit bias, it's absolutely important. It's definitely there. And there have been studies that have assessed the association between implicit bias and recommendations that providers make. And it definitely has shown that providers who demonstrate implicit bias will act differently in terms of serving racial, ethnic, minority populations. So that research is absolutely there, but that occurs in the healthcare sector. And so I think what social determinants is saying, let's look at the things that are outside of that as well. So I think you have to use all of that information together as opposed to saying one takes priority over the other.
Thanks very much. Yes, please.
So a question has come in asking about what I believe he's referring to patients with SS. And the question is, should we ask, and I hope maybe ask of the data, if they have access to specialists who can address SS? I think the question I'm guessing, and maybe the asker can clarify a little bit, but sort of the question that I was formulating, which is about this from the other side. So we've talked about social determinants of health, and maybe to also think a little bit about sort of the problems, the systemic problems within the healthcare system, in particular with sickle cell disease, the lack of access to care, and to also think a little bit maybe and address maybe how these data might be able to quantify some of those issues. I wonder if you've thought about that.
Right, and so I think, what would be helpful in some of the research, if it was possible, to maybe do some studies specifically in sickle cell disease, looking at implicit bias. So there's the instrument called I think it's the implicit implicit bias assessment test. Something is the term they use is IAT. So that's what assesses implicit bias. And so I think what would be meaningful is, from a research standpoint, if you could look at how providers score on the IAT and look at what they do in terms of care. And what a lot of researchers have done is usually the way they do it is with clinical vignettes. So they'll have the providers fill out the screen about the IAT, demographics, et cetera, and then they'll also give them these clinical scenarios where they change the demographics, they may change the gender, they may change the race, ethnicity, and then see what the providers do with recommendations for a very standard clinical scenario. And so I think that's one possibility. The other way to, I think about it is in terms of just training providers who are taking care of patients with sickle cell disease, whether they be specialists or primary care providers, is in some instances in large institutions, if those providers could undergo some type of training with the IAT. And I think some institutions have invested in that. Mostly, I think at the medical school level with medical students, is just having people go through sessions where they actually take the test, interpret their results, discuss what the implications of their results are, talk about some of the research and data around that, and then be able to incorporate that into their clinical functioning moving forward. So I think from large databases, we're not going to obviously get consistent information about implicit bias, but I think the room that we could go is if we could do some studies where we do start to assess it among the providers who do take care of patients with sickle cell disease, and then find out, one, is there implicit bias there, and two, how does that influence the types of care management decisions they make?
Thank you. That's really helpful to frame some of the things that we're thinking about. A couple more questions have come in, and I'll let Faith address those.
Sure. One is, your point about collecting data on social determinants of health if you can't address the issues is a good point. The healthcare system will have limited ability to impact the social determinants of health. It could be a challenge to engage the other parties in the social determinants of health, such as housing, education, food access, etc. You stated that the California State Task Force is one approach, or I don't know if that meant state task forces in general. Do you have other suggestions for getting non-health groups on board?
So I think in terms of getting non-health groups on board, so that's a great question. So I think what this person sort of brought up is this question of, what is the incentive to actually do this? If you're a large institution, large adult hospital, or a large system, why would you even screen for this? Because it's going to cost money to figure out how to get it into the EMR, and someone's got to collect it, someone's got to figure out what to do with it if resources are needed. But I think where the push is coming from, as I alluded to in some of the slides, is I think the federal government is starting to make this push towards not only screening for social determinants, but actually actively incorporating into what we do from a clinical perspective. And I think where people will get incentivized is when there's more payment at risk. And I think that's what some of these CMS programs that I briefly discussed intend to do, is to really say, well, now there's an opportunity for you to get increased payment by addressing social determinants of health. And there is also the potential to be at risk for payment if you are not adequately addressing the social determinants of health. And I think where we are right now is in sort of the nascent stage where what CMS is doing is giving grants to states as well as to individual organizations to say, figure out the models that work, where you can screen for social determinants as well as start to address them. And that'll give us a good sense of how to actually do this moving forward and hopefully create some overall model that we can do this. Because as the person had written, no one's going to do this if it's just sort of doing good work for the benefit of society. There's got to be something at risk or some incentive, and I think that's what these programs, at least at the federal level, are attempting to do with Medicare and Medicaid. And I think what will happen is eventually the private payers will follow suit and also start to put those incentives there as well, because the incentive for payers is if you can address the social determinants of health to some extent, that lowers their costs. And so they're going to be invested as well. So I think that's where a lot of payers are moving, is that we're not just invested in social determinants because it's the right thing to do. It actually could save us money.
Thank you. I want to read a comment about social determinants of health and then follow up with a question from a different asker. The comment is, one of the ways to address social determinants of health is through coordination of referrals to resources available in the community. Typically, these are coordinated through community-based organizations who have relationships with social service organizations who are funded to provide them. For example, food insecurity, the Urban League, Catholic Charities, community food banks all provide this support. Coordination is a function of some of the local sickle cell community-based organizations. And then a question, I wonder if this current list of social determinants of health are precise enough to control for environmental influences to drive policy. Could there be latent confounders?
I think that's absolutely could be the case. I mean, I think even though, I think what the IOM attempted to do is really do a comprehensive study and figure out what is the core set of measures that we really want to assess, but there's still a possibility that there may be other confounders there that may also be at play. And I think as I alluded to earlier, there's also the question of maybe some of the social determinants we want to look at are going to be a little bit different depending on the condition we're looking at or the population that we're looking at. So for example, for sickle cell disease, maybe something we'd want to know is sense of stigma or health system bias. All those things that they come into the healthcare system with, they come into the door with, that may affect what happens with their healthcare. So I think there always going to be the possibility of other variables at play, and I think, again, we have to think about which ones make sense for sickle cell.
Looking for the next question. What advice would you give someone that would like to be more involved with policy as it relates to sickle cell disease?
So that is a magical question. So it depends on where you are. So I think there are a number of ways to get involved. I think if you are at an academic institution, the ways you could get involved are potentially talking to your Office of Government Affairs. So typically, academic hospitals will have an Office of Governmental Affairs, and they have an agenda for the hospital for the year that they're trying to carry out with the state legislature. And so it may be that sickle cell is on that. Most likely sickle cell is not on that. And so if you're an academic institution, what your role may be is to engage the Office of Governmental Relations and just see what they have to offer as far as sickle cell, make a case of what some of the areas are, maybe pull in some of the providers, whether it be physicians, nurses, social workers, that are really caring for this population, and start to put yourselves together and say, these are the things that we kind of see. Are there areas where we can partner and really go out and talk to legislators specifically? Because the Office of Governmental Relations has a number of relationships with legislators throughout the state, so they can set up meetings where you can sort of present what you see as priority areas and maybe specific policy suggestions, and work with that team to be able to develop something. So I think that's if you're at an academic institution. If you're at another type of community-based organization, I think there is the opportunity to partner up with an academic organization, or you could do it independently. And you can always contact the health policy advisor of a local legislator and meet with that person and really sort of present what you see as issues around sickle cell disease. And I think from the perspective of those legislators, what they really like to see is some really concise amount of information about the issue that you're talking about. So you don't come in with a 30-page brief, in quotes, to sort of demonstrate some of the issues. I think what they want is one-page bullets. What are the issues, what to do, and here's what I'd like to talk about. Because for them, they could take that one piece of paper and understand it pretty quickly and then pass it along to their colleagues. I think if you're going to independently discuss things with legislators, you also have to remember thinking about the environment that you're in. So how you approach your passion and goals for sickle cell disease in Massachusetts is going to really differ than how you do it in Texas. So maybe in certain states you're more talking about it as the right thing to do, improving healthcare. In another state, you may more fundamentally talking about it as a way to decrease costs. So if that's in Texas, that's going to get you further ahead, is talking about the potential to reduce costs and create equitable care. And so I think you also have to have the proper mindset of how to get involved. I think the other thing you have to understand if you want to get involved in policy as it relates to sickle cell disease, they're all the organizations, Sickle Cell Disease Association, there's the American Society of Hematology, so all those organizations will have some kind of policy/advocacy arm. So it's a great opportunity to get involved at the regional and national level. So those are other places to sort of find your niche if you really want some more understanding of what to do and how to do it. They can give a lot of guidance. A lot of times they have templates on how to talk to legislators or how to write op-eds. Op-eds is something that anyone can do. You can write issue briefs or policy briefs from whatever organization you come from. So I think a lot of these national professional organizations or advocacy organizations can actually help you do that. I think the one thing I would say is if you do want to get involved in policy, always make sure that you know who you're representing when you talk to legislators, because if you're at an academic institution and you go on your own, it's hard to disconnect yourself from the academic institution. And if you say something, then it goes back to your institution or their Office of Government Relations. That can get you into a little bit of trouble. And so from whatever type of institution that you're coming from, if there is a person that is in charge of policy or advocacy there, you definitely want to talk to them first, because they can give you the information as to how they could either work with you or how you can frame your discussions with legislators as a private citizen so that you can in some ways disconnect yourself from the institution that you work with. Because I think that's where a lot of people get into trouble, is they say, oh, I'm going to do it on my own, and they go out there and then they're representing an institution because it's hard to separate.
That's a good point. One other question. Darn. Sorry, I lost track of where it is.
Oh, top.
That is one question. It's going to go. It was, yes, from someone with a child who has the disease, who is also part of the Black Women's Health Study that happened years ago. The question is, do you think that some type of study can start among patients instead of providers?
Study around social, I guess I'm trying to figure out what type of study. I know that may not be in the question.
Right, I'm not familiar with the Black Women's Health Study. She's saying sickle cell.
So start with the patients. I don't know if she means that patients would do it on their own or whether it would be more focused on long-term outcomes.
I think she means could, patients and their advocates do studies on their own.
Oh, I see. I mean, I think, it's possible. I mean, I think the important thing is to find partners and, because there is some funding that you need to happen. So, for example, if a group of patients wanted to look at, say, social determinants of health among the sickle cell disease population, they'd have to think about what their target would be and who they could actually get to fill out those surveys and studies. And a lot of times there's so many resources at larger institutions, whether it be community-based organizations or academic institutions, that'll have the staff that can do those surveys, that can collect the information, that can put it together, and then analyze it as well in a way that's going to make sense to a broader audience. So I think I would say if from the patient standpoint or the family advocate standpoint, I think it's difficult to do that work on your own because you may not have the resources to do it. And I think there's a lot of frustration among the this population just because sometimes they feel like the work that they'd like to see done by researchers is actually not being done, or the questions they'd like to see answered are not being answered. And so I think even with that frustration, I think the better way to go is to still partner with people who do this more regularly, because maybe there's a way you can inform them and say, here are the priority areas, here are the things that we're thinking about, how can we partner with you and you do the work? Because I think from the patient side, I think it would probably be too much to take on independently.
Okay, a lot of last-minute comments, but we might not have time to hit all of them. I think one is, you know, any thoughts around researching immigration status as a social determinant of health? And then there's a couple more thoughts on gathering data on social determinants of health. You know, it might be challenging for smaller clinics, but smaller medical sites should be included in the data collection, and the additional thought that some of the social determinants of health information would be best collected by non-healthcare sites such as CBOs.
Right. So I think those
strategy to sort of address these issues.
Right. So I think the immigration one is a question I've heard several times. And I think that one's a tricky one because, you know, depending on where people are, asking those types of questions could put patients at risk. And so I think, you know, there are a lot of people who would love to know about immigration status, and, you know, maybe there are ways you could do it anonymously, but then you kind of lose the ability to connect it up with other information. And so I think it's a sensitive question to ask patients because when you put them in those positions, they don't know what that information is going to be used for despite what you say. So that's the immigration question. Then I think the other question about the difficulty of collecting social determinants, particularly in smaller practice settings, I think it's a legitimate one because, again, those practices may or may not have the resources to address intimate partner violence, food insecurity, all these other areas. What I've seen done locally is what some of the small clinics are doing. They're saying, okay, instead of asking this whole battery of questions, what we'll do is we'll just focus on one, and we'll make sure that we have the resources available to address it. So our focus is going to be on food insecurity, and so we're just going to ask this one question on food insecurity during each visit with our patients, and then if they screen positive, then we have a number of community resources we can connect them to, and then we can develop some way of sort of monitoring our patients making connections with those community resources. So I would say the approach that I've seen that tends to work is saying, okay, if I'm a small site, what I'll do is I'll just take on a smaller part of these surveys, and I'll focus on maybe one or two questions that I know we can provide reasonable resources to that patient for.
So I think that's all we have time for right now. Thank you so much, Dr. Raphael. Don't forget to like us on Facebook and visit our new webpage that Mary put out again. And thank you, Dr. Raphael, for a great presentation, and thanks for everybody else for participating.